Optimizing psychiatric health relies on a core set of measures that work in synergy to resolve or significantly improve mental health conditions. Making strategic changes to medication is one of these essential components, but it must be integrated with four other clinically proven components. Research consistently demonstrates that a comprehensive approach yields the highest success rate. This includes participating in weekly psychotherapy or, in more intensive cases, daily psychotherapy, several hours per day, within a structured day program. Additionally, the regimen must include daily physical exercise, a minimum of 30 minutes of rapid walk or higher intensity possible. Total abstinence from any disruptive substances is a non-negotiable requirement for clinical stabilization. This requirement covers street drugs, alcohol, marijuana, and any non-prescribed controlled medications. Furthermore, treatment success depends on the optimization of the clinical triad, ensuring consistent and restorative sleep, establishing a clear daily structure paired with a sense of purpose, and building a robust network of social support. When these lifestyle and therapeutic factors are combined with expert pharmacological management, the foundation for recovery is established. If a change in medication is deemed necessary and accepted by the patient, there are only six logical strategies available to the clinician: starting a new medication, increasing an existing one, decreasing one, adding or replacing a medication, or changing the timing of the administration of the dose. Each of these strategies follow a specific set of clinical rules to ensure safety and efficacy. By categorizing adjustments into these six options, the treatment process becomes transparent for both the provider and the patient. When starting a new medication, the strategy is to introduce an agent that precisely matches the diagnosis. The number one option is to select an FDA-approved medication for the specific diagnosis the patient meets the criteria for, or, at the very least, a medication with a well-established off-label indication for that specific diagnosis. Off-label means that it is not in the package insert, but there are convincing randomized double-blind placebo-controlled studies to support the use of a certain medication a certain way. The selection process must ensure the medication fits the diagnosis and aligns with the patient's unique biological characteristics. A sophisticated approach to prescribing also considers side effect matching, where a potential side effect might actually benefit the patient, such as using a sedative medication for someone with insomnia. Conversely, it is vital to identify which specific side effects the patient finds unacceptable, ensuring that they are not exposed to even a small risk of a complication they cannot tolerate. It is critical to understand that all these strategies serve as guidelines, an average way of managing medication that the clinician must customize. This customization takes into account the specific characteristics of the illness, the general health of the patient, and, to a significant extent, the preference of the patient after they have been informed of the pros and cons of each option. The clinician's role is not to tell patients what to do. Rather, the clinician generates rational options, explains the advantages and disadvantages of each, and assists the patient in their decision-making process. The patient must be fully educated on the expected benefits and potential side effects. Crucially, this conversation must go beyond the simple list of outcomes and include the actual statistical probability of these events occurring. Often ignored in standard practice, discussing the likelihood of both the feared side effects and the hoped for improvements allows the patient to make a truly informed decision. If a patient refuses to accept any proposed medication option because they realize they do not want to use medication at all, the clinician must inform them in no uncertain terms of the risks involved in not treating the illness or treating it only with the other four non-pharmacological components. If there is no immediate danger to self or others, if deterioration cannot be definitively ascertained to happen in the near future, and if the consequences of exacerbation remain vague, the clinician should request that the patient returns for checkup within days or a few weeks rather than a month or more. If the patient refuses even this frequent monitoring, they should be instructed to call the office only if they are ready to begin active efforts to contain the psychiatric problem, or to seek a second opinion about what needs to be done. Of course, all of this process must go in the chart. Patients must be informed about the significant lag time psychiatric medications require before the maximum therapeutic effect is reached. While initial changes or subtle shifts may be noticed within days, the full extent of a specific dose usually requires 6 to 8 weeks to manifest. Rare exceptions to this rule include stimulants and benzodiazepines, which typically achieve their full effect on the same day they are administered. Generally, medications with an immediate onset of action also stop working after several hours, whereas most other psychiatric medications are slow to start and slow to wear off regarding their therapeutic benefits. When adding a new medication, the process should begin at the lowest available strength. For sensitive populations, including children, adolescents, and elderly over 60, treatment should begin at half of the minimum strength available on the market. The dose should then be raised by 50% every week until the middle of therapeutic interval is reached. Once at this midpoint, the dose is maintained for 4 weeks to allow the medication to demonstrate its potential. It is important to remember that modest improvements after 1 or 2 weeks do not mean that the medication is a failure. Only after 8 weeks at a steady dose can one state with high degree of confidence that the medication has achieved its maximum benefit for the patient. If the maximum effect of a medication at a certain dose is not enough, then continuing titrating medication up to the improvement or side effects get in the way of further increase, or the maximum recommended dose is reached. If the medication is available in liquid form and there is a high concern for side effects, the clinician can use the liquid to start as low as 1/4 of the smallest non-liquid strength, titrating up by the same amount every 1 to 2 weeks. The strategy of increasing the dose remains the number one strategy that should be considered if a patient is not yet seeing results. Before switching the medications or adding new ones, the clinician should verify if the current medication has reached its maximum recommended dose or the maximum dose that the patient can tolerate and was in place for 6, preferably 8 weeks. This ensures that the current treatment is given a full and fair trial before more complex changes are introduced into the regimen. If the medication is not maximized, start increasing it using the minimum available strength every 1 to 2 weeks. The higher the dose, the larger the intervals between increases should be, unless pressed by severe or dangerous symptoms that require rapid resolution. Conversely, the strategy of decreasing the dose is reserved almost exclusively for managing medication side effects rather than resolving the symptoms of the illness. This is done to find the lowest effective dose with the best tolerability profile. The strategy of adding an augmenting agent is used when the primary medication has provided some benefit but insufficient for a full remission. In these cases, a second medication is added to enhance the efficacy of the first. While the list of augmenting agents is extensive and varies by diagnosis, the introduction of an augmentation follows the same careful titration rules as starting a new medication. Remember, the dose required for an augmenting medication to be effective is often lower than the therapeutic range needed when using the same medication as monotherapy. Replacing a medication follows a specific cross-tapering algorithm. The outgoing medication is typically decreased every week by the smallest available commercial strength until it is discontinued. Simultaneously, the new medication is introduced at either 1/2 or a full unit of the smallest available strength. If started at half unit, it is raised to a full unit after 2 weeks. If started at a full unit, it is doubled after 2 weeks. Changing the timing of the dose has a much more limited usefulness. It is primarily reserved for side effects that occur at disruptive times, such as moving a sedative medication to the evening to avoid morning grogginess, or adjusting the schedule for side effects like daytime tremors. A special case is the transition from oral medication to long-acting injectable neuroleptics. The injectable form requires 4 to 5 half-lives to reach a steady state, and the half-life varies significantly between agents, ranging from 1 week for Risperdal Consta to 45 days for Invega Sustenna. During this transition, oral medication must be continued to maintain coverage. Specifically, Risperdal Consta requires 3 weeks of full dose oral overlap before tapering the PO dose. Over 1 to 2 weeks, haloperidol decanoate requires 1 to 4 weeks of overlap. Abilify Maintena requires 14 days of full oral overlap before tapering the PO dose within 1 week. While Invega Sustenna has one of the longest half-lives, it presents a unique pharmacological paradox by requiring almost no oral overlap. This is because therapeutic concentration is reached very rapidly despite the long elimination half-life. Unlike other injectables that use esterification or microspheres, Invega Sustenna utilizes nanocrystal technology, allowing for a fast rise in blood levels of the active substance. However, even with this rapid onset, a cautious taper of the oral dose within 1 week of the first injection is still recommended. Ultimately, none of these protocols should be regarded as rigid rules. They are flexible guidelines that must be adjusted according to the specific medication used and the unique requirements of each individual case.